Before you prone your patient, make sure you gather all the supplies that you'll need, including an extra set of EKG patches, IV extension tubing, cloth tape for ETT, 6 pillows, 3 bed sheets, Mepilex light dressings, a bridle for core pack, and all hands on deck. Before you start, you need to make sure that you change the ET tube to cloth tape. Absolutely no Hollisters. Lubricate the eyes with ophthalmic ointment. Tape eyes closed with horizontal tape application. Ensure the patient is appropriate level of sedation and pain management. Ensure all lines, tubes, and drains are secure and of adequate length to allow complete turn to prone. And empty the ileostomy/colostomy bag. The steps for a safe pronation of a ventilated patient is follows. Number 1, assess for absolute and relative contraindications and discuss as needed with the intensivist. We will discuss this later in the episode. Number 2, disconnect tube feeds and unused lines. Get rid of it. Clean it all up. Number 3, undress patient and maintain privacy. Number 4, place EKG leads laterally so they are accessible once prone and remove the V lead. Number 5, and this is super important, that's why I have it capitalized. Respiratory therapy or a designee that you assign at the head of bed is responsible for the airway at all times. They're the ones that call the shots. Number 6, you'll need 2 to 3 health team members on each side of the patient, usually about 5 to 6 in total. And number 7, the team leader, the person at the head of the bed managing the airway, makes all the calls. Next, you'll place 1 opened flat sheet underneath the patient. Cover the patient with 1 opened flat sheet. Tuck the patient's hands under their hips. And place pillows on their chest, pelvis, and shins. Place a 3rd flat sheet over the patient and pillows. Wrap the patient in the 3 sheets as tightly as possible. Always prone by rotating the patient towards the ventilator. In this situation, the ventilator is that laundry. On the team leader's count, begin a 3-point turn. Please pause for our team leader to come to the bedside. Pause at each point to ensure patient safety prior to continuing. Make sure that you have the ventilator as she points and that the team leader is ready. And on the team leader's count, move laterally and away from the ventilator. Next, roll the patient on the side. And for the final turn, you prone the patient. Now, unroll the sheets and make sure the patient's head is neutral and centered. Adjust the pillows for underneath patients as needed. Place arms in the swimmer's position. The patient should be looking at the arm that is up. Do not overextend their joints. Head on a regular pillow unless otherwise directed by wound care. Knees and toes should be floated. Ensure all tubes, drains, and lines are correctly positioned. And inline suction to ensure patent airway. Put the patient in reverse Trendelenburg and resume all tube feedings and infusions that were held. Absolute contraindications for proning include increased ICP of greater than 30, unstable spine or at risk for spinal instability/traction, weight of above 160 kilograms or 352 pounds, ECMO cannula placement problems, open chest or unstable chest wall, unstable pelvis, tracheal surgery that does not include a trach placement or sternotomy within the past 15 days. The relative contraindications that should be discussed with the intensivist if benefits outweigh the risks are a recent trach within the past 72 hours. Anything less than 72 hours, you must defer to surgeon for approval. A bifurcated ETT or difficult airway intubation. Anterior burns of greater than 20% body surface. Pregnancy, which is dependent on the gestation. Open abdomen or increased intra-abdominal pressure. Wound with moderate risk of dehiscence. Severe facial trauma. Bronchopleural fistula. Freshly placed PPM within past 48 hours. And all VADs require a cardiothoracic surgeon approval. The ongoing assessment of a prone patient is Q2-hour assessments of level sedation and pain management per standard of practice and as needed before, during, and after proning or supining. Q2-hour vascular assessment of upper extremities during repositioning. And lastly, Q4 skin assessment including under devices. Some additional MD orders to consider are the duration of the prone, which is typically 16 to 18 hours, duration of supine, which is typically 6 to 8 hours, ABG timing, tube feeds and getting that order to bridle the tube, ophthalmic ointment, GI motility agent if not included in any other order set, and a wound ostomy team eval and treatment. And lastly, emergency management. In case of patient coding, begin CPR and chest compressions with patient in the prone position. Compressions should be performed at the level of T7, which is the inferior angle of the scapula. And CPR should continue in the prone position until patient can be safely turned to supine, ROSC is achieved, or the patient expires.